So we're back doing regular content, and I've been getting a lot of requests and a lot of questions with regards to the Partograph. I've actually done a video before on the Partograph, but I actually realized that there are some few things that I did not emphasize in that prior video. If you want to check out that video, I will leave a card tagged right here that you can actually go and click. I'll also leave the video tagged at the end of this lecture. This is mainly just talking about Partograph exercises and some common mistakes that people make when plotting the Partograph. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at Partograph. We're going to be looking at specific exercises. We will look at common errors made when plotting the Partograph, and we'll have a look at a quiz that will comprise of predominantly 3 questions, and I will leave you a bonus question at the end so that you can actually comment in the section below, and so that you should be able to see if you actually understand the exercise. I will leave a pinned comment of the first person that actually gets the answer correct. And if you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon to be receiving such notifications of amazing content every time I post. Grab a piece of paper and let's go. So remember that the Partograph is the most commonly used tool to monitor the well-being and the progress in labor. It's pretty much a graphical representation of the progress of labor. It's going to provide this timely intervention, or rather helps you provide a window where you can actually know when to actually intervene timely. And it's going to entail these recordings of salient features of both the mother and the fetus. Remember that the Partograph is going to be opened during the active phase of labor. There are generally about 3 stages. Some books quote 4 stages of labor: the first stage, the second stage, the third stage, and the 4th stage. The Partograph is going to be opened in the first stage of labor. Recall that the first stage is divided into 2 phases. We have a latent phase where someone has these regular uterine contractions and a dilatation from a closed cervix to 3 centimeters dilated. We refer that to as the latent phase of the first stage of labor. Then we have an active phase of the first stage of labor, which is predominantly from 4 centimeters to fully dilatation, which is 10 centimeters. The Partograph is opened during the active phase of labor. So remember that it's going to be used to detect labor that is not progressing normally. It indicates when you can actually augment the labor if it's appropriate, especially in prime gravidas. It also helps you recognize cephalopelvic disproportion long before obstruction actually occurs. You can also recognize some signs of fetal distress on the Partograph. I talked about all these in the prior lecture that I leave tagged at the end of this video. Remember that the Partograph should only be started when the woman is in the active phase, so meaning 4 centimeters or more, and the contractions must at least be 1 or more in 10 minutes, each lasting at least 20 seconds or more. So they must be mild, or rather, they must be mild or moderate or severe or strong. So we have certain indicators on the Partograph, or rather I like to call these sections on the Partograph. We have the demographic section, we have the fetal indicators, we have the maternal indicators. Fetal indicators are things like the descent of the head, the fetal heart rate, and amniotic fluid, which is going to consist of the color, the odor, the quantity, and as well as presence of molding. Maternal indicators include the vital signs, the heart rate, the blood pressure, the temperature, the time of spontaneous or artificial rupture of membranes, any uterine contractions that are present, cervical dilatation, urine output and urinalysis findings, and any drugs that are administered, including oxytocin and antibiotics, among a few of the examples. So in our previous video on the Partograph, I actually showed you guys this Partograph on the right. It's just pretty much similar to this one that you see in most antenatal books. The only difference is that we added a bit more details on the demographic section. The name of the person, the LMP, the estimated date of delivery, the gestational age in weeks, and also the facility where you are, the hospital file number. So these are the ones that you're going to find similar photographs in your new antenatal cards, and you won't find these ones that have quite limited information on the demographic section. So what are some of the common errors that people often make when plotting the partograph? One big error is them not plotting the first mark on the alert line. What do I mean by this? So before actually going to the next slide, let me just preempt the second point, meaning that they're going to be plotting these plots on the partograph that are made on the wrong side of this line. So the first one is actually linked to the second point, and I will explain it further in the next slide. So here's an example one. So as you can see, this woman came into the facility at 5 p.m. She was 5 centimeters dilated, and the person that was seeing the individual was instructed to open a partograph. Now, in this exercise that is actually shown here, as we can see, the partograph was plotted here at 5 centimeters. Now, if you actually see this wasn't initially plotted at the alert line. So we should plot our findings along the alert line. So if this woman came in at 5 centimeters dilated, as opposed to us placing the mark here, we should have actually placed our 5 centimeters over there. So this 5 centimeters must have been placed over there. So our time 0 will actually be placed at this line. So this is the line that we'll consider as time 0. Anything that happened before that, we were not there, and we're not so sure what happened before that, such that if you count 4 hours from this, so you're going to be at 5 centimeters, we count 1, 2, 3, 4, 5, we expect this patient to be fully dilated. This is actually a good example. In this case, this patient was fully dilated, but if this patient, suppose, came in at 5 centimeters, then you plotted your 5 centimeters here, then you assess her 4 hours later and you realize that she's 8 centimeters, or you realize she's 9 centimeters, you would deem that as adequate, because this person would still be at the alert line. But then if you actually were to see where this plot should actually go, it's if there were 8 centimeters and you started plotting at 5 centimeters, 4 hours later, 1, 2, 3, 4, the 8 centimeters will come here, meaning that she's on the right side of the alert line and she's almost reaching the action line. So it means that she has crossed this alert line, and we must be vigilant in this particular woman. So this is one very common error that people often make when plotting the partograph. Same thing if someone was actually at 8 centimeters, you would just come and see where is 8 centimeters, and you trace and you make your plot along the alert line. Remember that these lines are placed in such a manner that the assumption that we make is that the dilatation of the cervix is going to be about 1 centimeter per hour. So remember, once you now make these plots, it means all the plots on the partograph, because remember the partograph is an entire graph. So let me just go to this entire graph here. So if we make our plot at 8 centimeters over there, it means all our first readings should be along this same line. So don't plot the other readings on the left side of this line, they must be plotted on the right side of the line. So if you mess up the first plot, it actually affects all the other things that you're going to be plotting on your partograph. I really hope that makes sense, and I hope you guys have actually understood this particular concept. So we'll begin with the questions. So question 1, interpret the following partograph. So I will give you a few minutes to pause the video, look at the partograph, and see if you can actually interpret what is going on. Okay, before I actually display the answer, remember, for any particular investigation, you always must make sure to see who is this investigation, who was it done on, when was it done on. So the demographics are always quite important. I did not include the demographics in the explanation, but on your exams, please make sure that you mention about the demographics. So here's the answer. So first of all, looking at this woman, so this is Mrs. J, who is a prime gravida, so she's a G1 para 0, and with a hospital file number of 1443, admitted on the 2nd of the 5th month, which should be, I think, May 2000, admitted at 10 a.m. and the membranes ruptured at 13:30. So when we look at this Partograph, this woman was admitted at 10 a.m. as we can see here. So the first thing that you must actually look at is this section here. So this woman was admitted at 10 a.m. and as we can see, she was admitted at 4 centimeters dilated with a descent, or rather a fetal, the station of the fetal head was 5 out of 5 per abdomen. Then the descent, not the station would be on vaginal examination, but the descent of the head was actually 5 fifths, so 5 out of 5, so it wasn't yet descended. And this woman had 2 mild contractions in 10 minutes, each of them lasting less than 20 seconds. Remember, when we're shading the dots, they are less than 20 seconds. If we're shading the lines, they're between 20 to 40 seconds. If we're shading completely, it's about 40 seconds. Then this woman was then again reassessed at 12 hours. I don't know why they reassessed her at 12 hours, because you know that the vaginal examinations are supposed to actually be reassessed after every 4 hours. So this was actually frequently assessing the woman. So when we reassessed her at 12 hours, we realized that the fetal head was still 5 out of 5. The cervical dilatation was still at 4 centimeters. She was now on the right side of the alert line, and the contractions had not improved. Remember, this is a prime gravida. The membranes were still intact at this particular moment, so there were no improvement in contractions. Membrane still intact. The fetal heart rate still remained in the normal range. The maternal vitals remained unremarkable. This woman produced about 400 mils initially of urine, and generally, as we can see, the vitals remained remarkable for the mother, as well as the fetal heart rate also remained remarkable. Now, at 14, there was something that was special that happened. Now, when we realized that this woman actually was on the right side of the alert line, as we can see over here, this was, let's say, this is at 10 hours. So this is at 11, 12, 13. So at 13:30, it's 13:30 here, as you can see, artificial rupture of membranes was actually performed. So this artificial rupture of membranes yielded the clear liquor. And remember, whenever you do artificial rupture of membranes, you must perform a vaginal examination. Or whenever the membranes rupture, you must perform a vaginal examination. You must listen to the fetal heart. Why are we doing this? Number one, because there could be a possibility that there may have been a vasa previa. One of the early indicators is you see a change in the fetal heart rate. The second thing is you want to see if there's any prolapse of the cord or entrapment of the cord that you may pick up when the membranes actually rupture. So we do perform a vaginal examination. The liquor is actually clear. So once the membranes were actually ruptured, as we also saw, this patient was started on augmentation of oxytocin because there was no contraindication for augmentation of oxytocin. So 10 international units was actually added to a liter of IV fluids, and it actually ran at 15 drops per minute. And this was titrated to 30 drops per minute, then 30 drops per minute, then it kept at a constant of 45 drops per minute, and then the contractions actually were quite established, and they improved from 2 moderate contractions to 3 moderate contractions, and then eventually we had 4 moderate contractions. And in the last around 18 hours, there were about, actually 19 hours, there were about 4 strong contractions that we actually seen. So as we have also noted, is that this was really poor progress of labor because of the inefficient uterine contractions. Once the membranes were ruptured, there was no meconium, the fetal heart rate was reassuring, then you augment with oxytocin. And then, of course, as we can see, the cervical dilatation improved to 6 centimeters, then eventually to 10 centimeters. As you can see, this patient never crossed the action line, and the descent also improved after the rupture of membranes and augmentation with oxytocin to 2 out of 5, then eventually 0 out of 5. So the delivery actually happened at 20 hours and gave rise to a live male infant, 2.654 kg. And as we can see, that's what really happened with this particular type of Partograph. Remember also, you should be able to calculate the dosage of oxytocin based in milli international units. If you want to find that out, I'll leave a card again tagged here that you can actually click on to actually go watch that particular video. Question 2. Interpret the following partograph. Again, I'll give you some time. You may pause the video. And here comes the answer. So again, demographics. This is a partograph of Mrs. H. She is gravida 4, para G4, para 3. So it means she's had 4 pregnancies and she's carried 3 pregnancies past term. And the hospital file number is 6639. The date of admission was the 20th of May 2000. Was admitted also at 10 a.m. And the membranes actually, she came in with membranes that had actually ruptured already. So how exactly are we going to look at this partograph? So if we actually look at this partograph, remember when this woman was admitted at 10 a.m., she was 4 centimeters dilated, and she had a fetal head that was 3 out of 5 palpable abdominally, and she had 3 contractions in 10 minutes, each lasting between 20 to 40 seconds. She initially had clear liquor, but she had molding 1+. So it means the fetal skull bones were touching each other, and they could easily be separated. With 2+, they are overlapping each other, but you can easily push them apart with your finger. With 3+, they're overlapping each other, and you can't push them apart with your finger. Then again, 4 hours later, so this one is one that was reassessed after 4 hours, so this one was okay. Reassessed after 4 hours, we realized that the descent hadn't changed, so it was still 3 out of 5. She was now on the right side of the alert line with a cervical dilatation of 6, so we expected this woman to be at least 8 centimeters or above. Anything below that, you already know that there is some poor progress of that labor. So she remained at 6 she improved to 6 centimeters. Then the contractions slightly improved to 3 strong contractions that are each lasting more than 40 seconds, and now she even developed the 2nd degree molding, grade 2 molding, but the liquor was still clear at this particular point. Then at 17 hours, when she was reassessed, so that's again an hour before she was due, because if you're looking at the 4-hourly reassessments, you're supposed to be reassessed at 18 hours. So at 17 hours, we actually noticed that, actually before that, somewhere around 30 minutes after we noticed the 2nd degree molding, we noticed that there was blood-stained meconium. Blood-stained amniotic fluid. Then a few hours later, I could say maybe this is 1 hour, about 1 hour 30 minutes later, we noticed that there is meconium. So there was meconium-stained amniotic fluid, and the molding even at 5 p.m. was now 3+. The dilatation was still at 6 centimeters. The descent was still poor at 3 out of 5, and the contractions were still strong. So it wasn't a problem with contractions. Remember, if you get someone who's not a prime gravida, a multiparous woman that's poorly progressing, it's hardly ever the contractions. We only expect problems with poor contractions in prime gravidas. In these multiparous women, especially those that are towards the grand multiparity, although this one is not a candidate for grand multiparity, those with para 5 and more, then you don't expect them to be augmenting such a patient with oxytocin. So the contractions here are not the problem. So it means there must have been some other issue that was there. And as you can see, the fetal heart rate was showing a decline. Initially, when you saw this grade 2 molding, there was a decline, and then you eventually crossed the 100 mark at this particular time. At 16 hours, it crossed the 100 mark, though our threshold here is going to be 110, 110. So it must have been maybe at the 15 or 1630, somewhere there. So we eventually also had meconium. We had grade 3 molding. The fetal heart dropped to 92 beats per minute. So now this here, we had to make a decision. And the decision that was made is to take this woman for cesarean section, because this woman had arrest of dilatation and had arrest of descent in the active phase of labor. Remember that this woman had, in addition to this, had adequate uterine contractions. She wasn't dilating. There wasn't any significant descent. So if you compound all these things together with the meconium that was present, the grade 3 molding, there was some fetal distress to some element, and this is largely indicative of obstructed labor. Question 3. Interpret the partograph. So you may pause the video at this moment. And here comes the answer. So again, preliminaries. So this is a partograph of Mrs. M. She's prime gravida, and she was admitted on the 14th of May in 2000, and the time of admission was 10 hours. The membranes ruptured at 13:30. The hospital file number is 1248. So again, here, this woman was admitted at 10 a.m. And as we see at 10 a.m., she was 4 centimeters dilated with a descent of 5 out of 5. She had an inadequate contraction. So she had 2 contractions in 10 minutes, each lasting less than 20 seconds. As you can see, this carried on for almost the entire labor. And she had intact membranes. And then after how many hours is this? 1 hour, 2 hours, 3 hours, about 3.5 hours, membranes actually were said to have ruptured after 3 hours. And remember, once membranes rupture, you should actually do a vaginal examination and assess the state of the liquor. So somewhere around 14 hours, this woman was reassessed. So there was clear liquor that was there. The cervical dilatation was still at 4 centimeters. The descent was still at 5 out of 5. And she had still inadequate contractions. Now they had even dropped to 1 contraction every 10 minutes, lasting less than 20 seconds. Then not even for 2 hours later. So, because if you look at this, if you assess her at 14 hours, so it means she was given some 2 hours later to be, or rather, I don't know why they give her a long period of time. They assessed her at 6, so they gave her 4 hours. So they reassessed her again at 4 hours, and they noted that now the dilatation was at 6 centimeters. The descent was actually 5 out of 5 still, and the fetal heart rate here was dropping, and it wasn't even being recorded. It wasn't filled out adequately, so it wasn't being done every 30 minutes. As you can see, there are some readings that were left out, but still the liquor was clear for this woman. So there was no further progress that was there for this woman, and actually a Caesar was actually ordered for somewhere around 21:20, and this actually resulted in a live female infant, 2.65 kg. As you can see, there was even some meconium at some point, meconium stained amniotic fluid, so there was an element of fetal distress in this type. As you can see, this entire partograph wasn't adequately filled out, and this was indicative of prolonged active phase of labor. One thing I forgot to actually mention on the previous question is that, as you can see, there was a live male infant that was delivered via C-section at 17:30, and the fetal weight, you can see 4.6 kg. No wonder this actually was not really progressing. Then here's the last question that I would like to leave on your minds, to actually leave your comments in the section below, and I will leave a pinned comment of the person that gets everything correct and explain this adequately. What is your interpretation of this partograph, and what are your answers? You may pause the video, look at the partograph, comment in the section below. I really hope you enjoyed this video on the partograph exercises. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.